everyone to this very special show. Manipal Hospitals and Network 18 present the Can Conquer Cancer Initiative. According to WHO's latest World Cancer Report, 1 in 10 Indians will develop cancer during their lifetime, and 1 in 15 might even die of the deadly disease. And that is an alarming statistic, one that Manipal Hospitals, one of India's foremost multi speciality healthcare providers, understands very deeply. And that is where this initiative comes in. It aims to deliver the right information to the public and combat the fear that once you have cancer, it is all downhill. So, through a series of interviews with prominent oncologists, Network 18 and Manipal hospitals are hoping to further the understanding of cancer and contextualize information around cancer prevention, its diagnosis, and treatment. So, today we are talking to leading medical experts from Manipal Hospital's own fold. So let me begin by introducing our esteemed panelists. We have with us Dr. Gunjan Bejal, radiation oncologist, Manipal Hospital, Goa. Dr. Shubham Jain, head of surgical oncology, Manipal Hospital, Delhi. We also have with us Dr. Som Shekhar, chairman, surgical oncology, Manipal Hospitals. And Dr. S. Murli, head of clinical services, Manipal Hospitals Group. So thank you so much, doctors, for joining us today and taking out time from your extremely hectic schedules. So let's start from the basics. We all know that early detection is key, but once we have a diagnosis, what is the process? Dr. Shekhar, if you could take this question, please. And if you could also tell us a little about cancer care pathway.
Thank you very much, Ruchira. You know what we have noticed, unlike other diseases, the moment we give a diagnosis to patient, there is a denial because, people think cancer is such a major disease. Not many know it is now like a chronic disease. Most of them are cured. They live a normal, healthy life. But the first thing before I give a diagnosis in cancer is I make sure I'm doubly sure because we need to confirm the diagnosis perfectly before I break in. Second, this is not like telling you have a hypertension, diabetes, oh, you have appendix. This can potentially change the patient and the family first time. So normally I have the patient and then we have a counseling and then I break it in a very nice positive way. So once we have a diagnosis of cancer, the onus of counseling the patient, breaking it in a nice way. Remember, first experience is the best experience, lies with us. This is an art. Every oncologist, as a human being and passionate and compassionate human being, as a friend to the patient, breaks it well. Once you
All right.
slowly break the news, then we have four paths. We confirm the diagnosis, then we stage the cancer and we institute the appropriate cancer. For this, at Manipal hospitals, we have something called as care on call.
All
Remember,
right.
patients go through denial, anger, depression. So
Of
we
course.
tell them
Various
that,
stages.
this is curable.
Mm-hmm.
We have a care on call group where we take them through the whole navigation path. Before the
All right.
diagnosis and the treatment starts, there are different paths. And it's
Mm-hmm.
very tough for them to navigate. That's why this care on call, care on path at Manipal hospitals in oncology department we go through coordination, counseling, multidisciplinary tumor board, which is the optimal treatment. No two cancer in the same patient, same stage is same. It is very important. It is the era of personalized medicine.
Mm-hmm.
So we stage the disease, then we make the patient and the family partner to the decision making with a group of multidisciplinary tumor board. Then we let the all the information in terms of one-to-one discussion, audiovisual and educative material we share it with the patient. I
All right.
normally give some time to the patient to digest and then let them know what is the right treatment way ahead. And also, every patient is different. They may be athlete, there may be a traveling person, there may be doctor, they may be professional, they may be
Mm-hmm.
homemaker. Their priorities and their goalposts we understand. And then we institute the definitive treatment to them, which could be surgical, medical, radiation, hormone therapy, in that priority, making patient into one. So it is not treating the disease, the whole human being as a compassionate and the whole family. So that is where this care on call and cancer care pathway we have in patient with coordinator, counselor, with the
All right.
family and tumor board plays into play.
All right. Thank you so much, Dr. Shekhar, for sharing details about the cancer care pathway. As you mentioned, there are different stages when it comes to tackling with something this big. But I'd like to come to you, Dr. Bejal. Could you elaborate on the tumor board and how does it really pan out and how does it operate?
Yes, thank you, Ruchira, for that question. In fact, as Dr. Somshekhar has said, we have probably realized over the period of years that cancer treatment is essentially not the ball game of a single specialty. It is a multidisciplinary care. So, a tumor board basically is a conglomeration of doctors involved in treating a cancer patient from the diagnosis to its final outcome.
Mhm.
So in a tumor board, you would have large number of specialists like that from the surgical oncology team, the radiation oncology team, the medical oncology and the hemato-oncology team, a pathologist, a nuclear medicine
Right.
specialist, a diagnostic and an interventional radiologist, a psychologist, nutritionist, and a social worker. So all these doctors would actually be required to see all the cancer patients and discuss their reports and eventually formulate a complete diagnostic, therapeutic, as well as a rehabilitative plan to give the best possible chance of an optimal outcome for this patient. So
All
for
right.
this, the basic requirement is that all these specialities need to be under one roof in a hospital. And when that
Mhm.
happens, it alleviates the need for the patient to seek multiple opinions, which often leads to delay in treatment diagnosis, and possibly this is what very many a times impedes good outcomes for the patients. And this is where the tumor board really helps in instituting the right, correct, and rapidly the management for the patient.
All right. And do you find that being part of a large hospital chain like Manipal Hospitals improves the tumor board and how it functions in any way?
Yes, it definitely does. As of now, I cannot correctly recall as to the number of hospitals that are there with the Manipal Hospital group. It's an ever increasing chain. But what happens is when we have so many hospitals, what we see essentially is that all these hospitals are equipped with all the specialities under one roof so that the maximal
Mhm.
possible care can be instituted to the patient in one particular place. However, for some
Sure.
specialized treatments, patients can be referred across the hospital chains for equipment based treatment, for example. Or doctors can reach out from different hospitals of the same group to the patient, and complex procedures can be performed in even remote areas. For us as doctors, educationally and patient specific discussions and experience can easily be shared across, by the doctors intertwining between the tumor boards of each of these hospitals and discussing their patients and gaining from the experience of other doctors in similar cases. And this
All
is what
right.
is very important. And one very important aspect of our group per se is that not
Mhm.
only do we have hospitals, but we also have medical colleges, which gives us an additional sort of an advantage in being able to that can serve as an advantage many a times, because we can take from the experience of the medical colleges as well. And proud to say that I am a product of Kasturba Medical College, Manipal.
All right.
Uh, uh,
Great.
Ruchira, if may
Also,
I just add a point with your
sure, sure,
permission?
sure, sir.
In Manipal group, we have this Manipal Comprehensive Cancer Center where we have three types of tumor board.
All right.
If you like visit, we have a tumor board placed in our outpatient because medical, surgical, radiation, nurse practitioner, pain specialist, palliative, everybody is busy. If you say come to this floor at this day, it's not going to happen. That's the beauty of the forefathers and the great management, headed by our CEO and Dr. Murli and all of them. That not many hospitals do that. Like, if you come, we have a tumor board placed in the OPD. So one type of tumor board is institutional tumor board. 90% of the patients are case forward within the institution, all of us discuss. Second, most of our tumor boards are equipped with state of art, video equipments where we do video consultation with other center across India. Manipal has a lot of cancer center across India. This is the second type of tumor board where, for example, we need a stem cell transplant, we connect to that group, robotic to this group, high tech this group. Third type of tumor board we have, like, just last week, Manipal group as itself had a joint tumor board with Memorial Sloan Kettering in New York, where those expert, our expert, we had a discussion. So we have three types of tumor board. Institutional tumor board functions regularly. And then there is a video call equipment between all of them, where we do between all the centers. Then we have it advanced center. The beauty is all of them are bundled as a part of comprehensive cancer center, with extensive foresight of the management support which we have.
So, Dr. Jain, what I'd like to understand from you is that do tumors necessarily involve surgery? And in terms of progress in technology, how does India currently stand in comparison to the West?
So, Ruchira, most of the tumors, the solid organ tumors that we talk about, they do have surgery as an integral component in the treatment. But as Dr. Somashekar and Dr. Gunjan were talking about, tumor boards have now come as a mainstream in the planning for treatment for these patients. So
All
it's
right.
the sequencing of surgery also that is important. What the oncologists have realized is that, as previously was thought, that removing the organ that is affected with cancer gives the best results. That is not entirely true, because we now understand the importance of sequencing. So many a
All right.
times there are cancers which need chemotherapy or radiotherapy to shrink the bulk of the tumor and to make the surgery more effective. Similarly, there are instances, depending on the stage of the cancer or the location of the tumor, that the surgery itself may be too morbid or having too many side effects for a particular patient. So that is
All
what a
right.
personalized treatment in cancer is called. So if the patient is probably too frail to undergo a surgery or to tolerate the side effects, then in those
Mhm.
patients we tend to avoid giving a surgical option in view of the patient's general health, and we treat them with other modalities. Having said
All
that,
right.
there is no denying the fact that for majority of solid organ tumors, surgery is
Mhm.
an integral component of the treatment for the patient, and it probably offers the best chance to cure if the patient can tolerate it. There are certain cases of advanced stages where initially it was thought that probably surgery will not benefit, but that scenario is also a changing landscape now. And with better understanding of the cancer biology, these are also coming within the realm of surgery at some point in the treatment.
All
As
right.
far as the results compared to the West are concerned, so if we were
Mhm.
talk about stage to stage comparison, because in India, as a developing country, we are seeing patients predominantly in more advanced stage of disease. So I would be proudly saying that we are quite closely matching to the results in the West
Right.
stage for. But unfortunately, because we are a developing nation, we still detect patients at an advanced stage where the chances of cure are slightly lesser and the treatment is difficult, more expensive for majority of the patients to afford.
All
So,
right.
because of that, probably we are lagging in our results when we are talking of cancer in general. But
Mhm.
that situation is also changing with the help of such platforms where we're trying to raise the awareness for cancer and towards the treatment of cancer uh, that we see now across our patients.
All right. Great. So, Dr. Jain, as you said, there has been remarkable progress made, but there is, of course, we have miles to go ahead as well. But
Absolutely.
a treatment plan, as you mentioned, consists of various stages and various combinations like radiation, chemotherapy, surgery, or even immunotherapy. So, it is, of course, about a lot of planning and consultation there. But coming to you, Dr. Bejal, if I ask you the same question as I did to Dr. Jain, that how has radiation therapy really changed or improved in the past decade, and what are the common myths that you encounter when you are interacting with your patients?
Yes. So if I were to put it very shortly and sweetly, I would probably say that technology, precision, and accuracy are the three words which have actually increased in leaps and bounds and made radiation very much more acceptable now with
All
respects
right.
to improved cure rates and much lesser long term side effects. In fact, so much so that of all the cancers that are cured, radiation
Mhm.
plays a major role in curing about 40% of these cancers. So, coming back to technology, there are techniques like the intensity modulated radiotherapy, image guided radiotherapy, volumetric modulated arc therapy,
All
SRS,
right.
SBRT. All these techniques can be planned on sophisticated computer systems and can actually deliver maximum radiation to the areas affected or likely to be affected by tumors while limiting the dose to the normal structures to the minimum possible levels. So, this
All right.
allows increasing the tumor killing dose to the tumors and lesser normal structure damage. So patients get effective cancer cure or palliation,
No.
low chances of side effects, a good quality of life, and a real good chance at organ and functional preservation. So the myths, as one might come across, are related to this. They are very similar to people feeling that the chance of cure once you are diagnosed with a cancer is
It's
absolutely
very limited.
minimalist, or the
Mm-hmm.
side effects are too bad, so they don't want to come to the centers. But all these myths arise essentially from their lack of knowledge of the current technology and the leaps and bounds in which it has actually moved forward. and
Mm-hmm.
and what is actually happening because of these myths in the society and the lack of knowledge is it is leading to, as Dr. Shubham said, very late presentations. And at such a stage, even these advances in technology are when many a times not able to help these patients, which actually leads to the given up attitudes of the patients and their relatives, which can only
All right.
change with education, as we are trying to do through these programs.
Great. Thank you for sharing that, and that is truly very insightful there. Dr. Shekhar, how has chemotherapy evolved over the years? And specific to HIPEC and PIPEC therapies, could you share some more details about these therapies and how do they really function?
Sure. Like last almost 25 years to 30 years, the way I saw the change in the cancer treatment. I was trained in India, then I was in US and UK. I got trained there. In cancer, we initially thought maximum tolerable treatment because disease is bad, bombard it with maximum chemo, radiation. But now we understood that this is not an era of maximum tolerable treatment, but an era of minimum effective treatment,
Mm-hmm.
keeping in mind the oncological principles, cure, then organ preservation, quality of life of the patient, and
All right.
multimodality. And this is an era of organ preservation protocol. So there are two spectrum of cancers. We have an early cancer, which is very rare in India, and an advanced cancer. So there is a group of cancers which are caused by ovary cancer, stomach cancer, colon, intestine, where
Mm-hmm.
most of them come when it has spread everywhere in the tummy. And then usually they are stage 4, and traditionally they were not curable. But now, since last about a decade, a new treatment called as HIPEC, that is a hyperthermic intraperitoneal chemo, or a PIPAC, pressurized nanoparticle chemo. What we do is, when we do a surgery and remove the tumor and give a chemo by IV, not
Mm-hmm.
many are cured in this advanced cancer. Most of them are palliation. But now this
All right.
era of new treatment called as HIPEC pump. This is a technology which is there from Italy and US, which we are
Mm-hmm.
very proud and happy to tell the first institution in India ever to do is at Manipal Group. And then this is the leading center under Center of Excellency and Referral Center across the world for these
All right.
non-curable cancers in the tummy, from ovaries and gastric and colon, where we do the surgery and we have this special pump. Like, you have a dialysis for kidney and liver, like that. This is a
Mm-hmm.
special US FDA approved machine.
All
Manipal
right.
hospitals were the first to procure these two state-of-art US FDA approved machine 10 years back, and the largest number of such procedure called HIPEC and PIPAC in entire Asia is done at Manipal cancer centers, where we do this, use this pump, and then the non-curable cancer go up to 70 to 80% curable. And PIPAC is a nanotechnology, pressurized German technology, which was started first in India in a Manipal group of hospital, which we do. So those cancers which are not curable are amenable for the long survival, like 5, 7, 8, 10 years, and like appendix cancer, and patient derived this benefit because of this technological innovation. So I can say that this is something where an advancement technology has come there, and Manipal Hospital and Manipal Cancer Center are the leaders and center of excellence in referral center across Asia for this particular technology.
All right. Thank you. Thank you for that. And those are really some commendable achievements. But I understand you also have experience in robotic surgery. So, what does that really involve, and how much control do the doctors really have?
Yeah, the era is, I don't know if you see that most of the time patients are afraid to come for cancer surgery because they think the treatment is more dangerous than the surgery. I ask everybody, why are you afraid? Oh, I just know. I come, you remove my organ, you will cut me from here to here, and I lie down for 2 weeks. The pain, rehabilitation, me, my family had to go through for three. Yes, this was actually true even about 15 years back, until this robotic technology came. We are very proud to say we were one of the first hospital 12 years back to procure it at Bangalore Manipal Cancer Center. And now the largest number of keyhole robotic cancer surgeries in entire India is done by our group in the Manipal Cancer Center. The advantage is the same major surgery are done through 8 millimeter keyhole with this robotic technology. This is a thing which is developed by Indian scientists in NASA collaboration with Stanford in US but came to India.
All
What
right.
happens is there are 4 arms and the camera of the robot which surgeon uses magnify the tissue 12 times. So I can see cancer cell, lymph node, useful nerves required for body function, sexual function, urinary and
Hmm.
normal organ, abnormal organ. 4 arms, there are laser, there are special vision and surgeon
All
sits
right.
and operate. The same quality of surgery is done with keyhole, fast recovery, no blood transfusion, no need for ventilator, less pain, early discharge with excellent cure rate. So now this has become a norm. I'm proud to say that even in the pandemic time when patient has to go home early, not stay in hospital, over
Hmm.
536 robotic complex cancer surgery was done in Manipal Cancer Center. And now patients are very happy. They come asking for that. We have this international patient care. All the patients come asking because we are a center of excellency. Most of the Manipal group of hospital in India, including the one in Delhi, in Bangalore, are equipped with state-of-art fourth-generation robotic technology. So
All
now
right.
no longer treatment is more dangerous. It is most pleasurable, tubeless, painless, scarless. Recovery surgeries are done, which gives an optimized treatment, which has revolutionized the treatment for cancer patients.
All right, great. Thank you for sharing that. Dr. Jang, were you also speaking about organ preservation and cosmetic scars? Were you referring to robotic surgery as well?
So, Ruchika, the uh, concept now for cancer treatment, a lot of focus is on the quality of life that the patient has. One of the ethos that Manipal Hospital has is patient centricity, so which essentially means understanding what the patient wants out of the treatment. Uh, Being able to provide such functional outcomes which help the patient get discharged early, return to the work faster, definitely do improve their quality of life. In addition to the benefits of the robotic surgery, what I meant with functional surgeries or cosmetic scars was more of being able to preserve an organ. For example, if a lady is suffering from breast cancer, now the thought of getting the breast removed is a standard view, but the feasibility of saving the breast for her in case she is detected it in time, which can be
Hmm.
offered by breast conservation surgery. It requires a lot of infrastructure like the nuclear medicine department, the pathology department, frozen section, for us to be able to deliver that result, which is what helps a good comprehensive center like Manipal Hospital actually be able to deliver that. Good plastic surgical techniques are required for whole breast reconstructions. And such functional surgeries are not just limited to a particular organ like the breast, but they also go into various other organs like limb salvage surgeries that can be offered to patients having a cancer in one of the limbs. Throat cancer patients can have functional surgeries wherein, with the help of laser, we're just able to remove the tumor if
All
it is
right.
detected early. So that is why cancer treatment is a lot based on the infrastructure that is
Hmm.
available and also on the awareness of the patient, so that they're able to come in time and we are able to actually offer these beautiful surgeries or treatment options to the patient, which can lead to massive improvements in the functional outcome.
All right. Dr. Murli, Manipal Hospital also has a strong track record of path-breaking surgeries, as you all have mentioned, and also pioneering new techniques and new technology. So, could you tell us a little bit about that?
So, meaning, I think most of this my previous colleagues have spoken about, but I just wanted to also talk about the platform. So, we had Manipal hospitals had the vision even 2 years, 2 decades back that oncology is going to be a major focus because of the burden of this disease burden in the society. So, what we did is we created a very good platform, and when we mean platform is that not only the oncosurgeons or the oncologists, radiation onco, but also to build, as Dr. Somshekhar said, a comprehensive onco care center. So once you build a comprehensive onco care center with surgeons, with technology, then our focus remained on two aspects. One is we should provide the best possible treatment for the patient what is available in anywhere in the world or closer to that. So that is where we did a lot of, you can even, some could even say that we ventured very early, but thanks to some of our wonderful doctors who are like Dr. Somshekhar and many others, it yielded us good results. We were, as Dr. Somshekhar said, were first to get into robotics, get into high tech. Not only that, we also expanded that. So one is in terms of technology, treatment, manpower, getting them comprehensive care. Another, equally, we invested it on preventive, because if you look at efficient screening and preventive aspects, that helps the community to detect them at large, detect the the population who are at vulnerable at much earlier than what they could have otherwise noticed. So these are the two areas. So as I said, the platform, technology, people who are very well trained, give them all the latest advances, what is there, which is available. And of course,
All right.
in addition to all this, the icing on the cake is to build a strong academics. Because once you build a strong academics, the people who come here and train, they are wanted all over the country. So because that also helps in delivering enhanced care for the patients.
Great. Very well explained, Dr. Murli. Thank you so much. Dr. Bejal, coming back to radiation therapy, could you tell us a little bit about SRS and SBRT? What are these cancers that you're seeing very high cure rates when radiation is combined with multiple approaches like immunotherapy?
Yes, so SRS is basically stereotactic radiosurgery and SBRT is stereotactic body radiotherapy. Even though the word surgery is there, but it is mainly a radiation procedure. And putting both together, we would probably term them together as a stereotactic ablative radiotherapy. So
Hmm.
these are extremely novel ways of delivering the radiation therapy. So normally radiation therapy is given in small doses of about 2 grays per day over a period of 5 to 8 weeks when we are trying to cure a patient. But with SRS
Okay.
and SBRT, the same
Hmm.
ablative dose of the tumor can be delivered in as short a time as a single day to 5 days, with delivering almost 10 times the dose, 8 grays to 30 grays per day for radiation therapy.
Oh.
And this has been made possible by the sophistication in the linear accelerator technology.
Hmm.
Linear accelerator is the machine that we use to deliver the radiation to the patient. The better ability to visualize the tumors by use of CT scans, MRIs, the PET CT scans, the ability to immobilize a patient tightly into one place so that the tumor motion is not too much or the patient motion is negated, but yet
Correct.
not doing it invasively has made this possible. The ability to target the tumor while accounting for respiratory motion of the organs like the lungs and the abdominal organs, which may move with respiration, has
Sure.
made it actually possible to deliver this kind of a high dose to the tumor and thereby control the side effects as well as increase the cure rates. Now, normally, radiation would
Hmm.
kill a tumor cell by just simply damaging the double helical structure of the DNA. But when we use
All right.
SBRT or SRS as a treatment, there are other
Hmm.
mechanisms which come to the forefront, like programmed cell death, damage to the vascular or the blood supply of the tumor, and it can also enhance the anti-tumor immunity of the patient after the radiation is delivered. And this leads to a greater chance of a remission or little or no side effects. It finds great application in sites like prostate cancer, whereby it can be radiation can be delivered curatively in a very short
All right.
period of time for the patient, non-invasively. For some patients who have got a medically inoperable tumor like that in the lung, they are not able to undergo surgery due to various comorbidities chronic obstructive pulmonary disease or an uncontrolled pressure situation or multiple bypass angioplasties and things like that. For these
All
patients,
right.
SRS and SBRT in lung can be used for these patients to cure. Pancreatic cancer is seeing a large shift to try and reduce the size of the tumor so that they can be made operable. In fact,
All right.
earlier stage 4 cancers were considered incurable, but now, if there are only small number of metastatic sites, up to 3 to 5,
Hmm.
from 1 to 3 to 5 metastatic sites, by the use of stereotactic body radiotherapy and
All right.
immunotherapy based on the molecular profiling, as many as 30 to 40% of these cancer patients can actually achieve a durable remission, which is actually miraculous considering the fact that a few years ago these patients were left in the lurch and had just nothing except palliation to be offered to them.
All right.
A lot of
Great.
research, in fact, being done in this direction to
All right.
extrapolate the immunogenic potential of radiation therapy and the immunotherapy. And I'm sure that this is the future way of going about for the treatments, and we'll see much more application in the coming times.
All right. So, Dr. Bejala, as an extension of that question, is it true that you are seeing more successes now with radiation as a curative option?
Yes, actually, if you ask me earlier days, the simplest indication for sending a patient to radiation used to be that the tumor is inoperable, we can't operate it, so send the patient for radiation. And
All
actually,
right.
this approach actually has catapulted radiation to the forefront, because when we
Mhm.
radiated these patients, we saw a lot of these patients had good and durable responses, and that is what actually is the real benefit of this modality which has come to the forefront. But the crux
All
now
right.
is not only
Mhm.
curing inoperable patients, but in today's day and age, the correct sequencing of treatments to be able to cure maximum number of curable cancers is very important. And in this
All right.
situation, one has to understand, as I told you, the example of the stage 1 or 2 lung cancer, where SBRT is
Mhm.
an option for medically inoperable. So, to identify these patients and not see that they don't give up hope, because there is a curative option available for them, even if surgery is not possible for these patients, and they should take it for these patients. The use of radiation for rectal
Right.
cancers, whether operable or inoperable rectal cancers, currently the way actually is to give radiation with some small doses of chemotherapy upfront and then take the patient up for surgery. This kind of an approach offers the patient a better survival benefit, and very often in almost 40 to 60% of the patients, the chance that a patient can live without a permanent colostomy bag, which is very important for the psychosocial and benefit for the patient. In lower
Mhm.
esophagus also, radiation therapy is very often used upfront before surgeries to give better resectability for these patients.
All right.
For cervical cancers, it is now more or less the treatment of choice beyond the stage 1 setting. And also for head and neck cancers, radiation in laryngeal tumors, in oropharyngeal cancers is extremely important. By delivering radiation curatively to these patients, we can in fact save them a lot of morbid surgeries and yet give them excellent cure rates with voice preservation and organ
Mhm.
preservation for these patients, which is immensely beneficial for these patients, as they can speak even when their cancer is cured. So which is
All right.
very good. So in fact, I will go on to say that as a patient, one must not give up hope, because at the end of that dark tunnel there is always a radiation oncologist with his rays of hope. Thank you.
Thank you, sir. Thank you for sharing that. In fact, I understand Manipal Hospitals has also recently begun using Radio Exact with Synchrony. Dr. Shekhar, could you tell us a little bit about that?
Yeah, one beautiful. See, like I worked in most of the cancer center across the world. I worked in UK, US, in Taiwan, and in France. But the thing I see in Manipal Group, the forefathers, the head of the organizations, the management, is patient-centric approach.
All
Nothing
right.
other than the best outcome for the patient and personalized care, and as if like every person has, like, there is a life around. If you walk in Manipal group of hospitals, you feel like family. When I leave morning hospital and I come, it's like it's like family. You don't feel you're coming for work. It's a family environment with patient centric thing. What was
Mhm.
thought was the best in the world should be first available in Manipal hospital. No patient in India should be denied the best in the world just because it is not available. So, in keeping with
Absolutely.
that philosophy, the best radiation machine, the first of its only kind ever, first in
Mhm.
India, is placed at the Manipal Hospital, Bangalore. The beauty of this is the whole concept of radiotherapy works in a three dimensional. Imagine, suppose there is something, there is a pen or anything in your hand, you see it in two dimension or three dimension as a body. And remember, we are treating living beings. Patient moves with respiration. So suppose we say there is a lung tumor or there is a tumor deep in the food pipe, in that area, in that position, it
Mhm.
changes every second. The new state of art machine we have taken is best optimized radiation to the cancer part, and image guided normal areas like the urinary bladder, the rectum, the intestines, and the heart and
All
other
right.
part lungs are spared. And it
Mhm.
also adjusts itself in a three-dimensional spatial area, the respiratory movement of the patient. So you think that patient is holding the breath now, and you go and start the machine, the patient will move. So this has got a real-time artificial intelligence built in, which adjusts spatially with image guided system built in this radiation machine, even taking into account the respiratory movement of the patient. So this has increased the fastness of the treatment, quick treatment in a given time, short duration, best maintaining the functional organs, not allowing radiation to scatter to the normal area other than the area the radiation oncology team wants to treat, also keeps into account the respiratory movement. So this is the first of its kind in India and the first machine which is put at Manipal hospitals, and this is not going to be the last. The best technology usually comes to Manipal hospitals for the benefit of the patient, keeping in mind the best academics, technology, and personalized care.
All right. Thank you. Thank you, Dr. Shekhar, for sharing those insights there. Dr. Jain, coming to you just before we wrap up, my understanding is that there are surgeries now that are used as preventive solutions when it comes to cancer. And that itself is quite a shift from when surgery was considered an end of the line treatment. So, what are your thoughts on this?
So absolutely, Ruchira. We all know about Angelina Jolie, who underwent a prophylactic or a preventive breast surgery just because she was having a significant family history and was quite a high risk for developing breast cancer. So similar to that, such surgeries are no longer just in the West now. At Manipal hospitals, we have genetic counseling for such patients who have a perceived high risk based on their family history or personal history of cancer. And once they decide amongst the various treatment options that are available, if they opt for a prophylactic or a preventive surgery, which basically means to take the organ which is at a high risk of developing cancer, we remove that organ, and that is the way we prevent these cancers for developing in the future. Now, what needs to be kept in mind is, because it's a preventive surgery, the patients are generally not keen on accepting the side effects of the usual surgery that a cancer would have had. So here again, the need for the technological advancements is paramount, and that is why we are able to offer such prophylactic or preventive surgeries. So, for example, if I were to speak of somebody having a high risk of developing cancer in the large intestine, previously a cancer of the large intestine used to have a incision in the whole abdomen, but now with the help of robotic technology, what Dr. Somashekar was elaborating on, we are able to remove this organ just with keyhole incisions, and the patient doesn't have a significant scarring or any loss of the quality of life. Similarly, taking again the example of breast cancer, we can remove the breast and reconstruct it with the help of plastic surgery techniques, so that the patient doesn't have a loss of symmetry or loss of body image. Such surgeries are actually changing the way a patient thinks, and it's able to address the anxiety of the patient more than anything else. Once anybody knows that they are at a high risk of developing cancer in the future.
All right. Great. Thank you for sharing that. So, Dr. Jain, we are just going to wrap up on this very insightful discussion. But one last question to you. Could you tell us a little about ERAS? What does it really mean for patients and their recovery outcomes at large?
So ERAS stands for Enhanced Recovery After Surgery. Now, this is a thought process of improving the patient outcomes so that they recover faster after the surgery. So it requires a lot of rehabilitation. The focus initially used to be on rehabilitation after the surgery. What we now believe is in rehabilitation, so as to make the patient fitter before the surgery, so that they are able to cope up with the after effects of the surgery faster, and we are able to discharge the patient quicker. What we have been seeing is there has been a paradigm shift in the patients are recovering from the surgery because of these protocols that we have now started involving in our daily practice and our daily planning for the patients for surgery.
So, thank you, doctors, for joining us today and having this extremely educative and insightful discussion. We had some of the best minds in the field of cancer treatment addressing common concerns and fears that surround the deadly disease. On that note, let me thank all of you for joining this show and for trying to educate us and give us the confidence that we really can conquer cancer, particularly when we are in such good hands. So, thank you to our audience for watching, and thank you all for joining in.